We have a question for you, Dr. Kim, from Julie. If a patient is ALK Variant 1 and has no targetable mutation at disease progression, when would you prescribe lorlatinib versus chemotherapy?
I think it's a good question. If we perform, blood-based and also tissue-based NGS and really thoroughly looking at everything, and then end up finding no targetable mutations, just the same ALK fusion variant 1, then we are left with a few choices there. Of course, lorlatinib has been FDA approved in this setting, and also chemotherapy. And I will probably discuss both options too with my patient. And because lorlatinib is a pill you can take, it's better tolerated than chemotherapy, though it has different side effect profile. I would probably suggest lorlatinib, but I'd like to hear from you, Dr. Lin, what your approach may be here.
Yeah, I agree with what you just stated, Dr. Kim. I think first question will be confirming that the method that was used to look for a resistance mutation was indeed diagnostic. So sometimes we are increasingly using liquid biopsies to look for different resistance mutations. And let's say there's a pretty low disease burden and a liquid biopsy is sent and an ALK mutation is not detected, but there's also really nothing else, then that would be a non-diagnostic liquid biopsy and you need to consider a tumor biopsy. Assuming that the biopsy was truly diagnostic and did not show an ALK resistance mutation, we have the phase 2 correlative analysis data that suggested that the efficacy of lorlatinib is significantly higher if there is an underlying baseline ALK resistance mutation. And so that is where discussing the relative benefits and risks of using lorlatinib versus chemotherapy becomes important if we know that a tumor does not have an ALK resistance mutation. I would say because lorlatinib is generally better tolerated than chemotherapy, oftentimes we might be inclined to give a short kind of trial of lorlatinib with short interval follow-up and monitoring of clinical symptoms so that we know we've tried it. It also depends on how the patients are feeling in terms of symptoms, how much disease burden there is. Do we think we have a safe window where we could empirically try lorlatinib before turning to chemotherapy? Those are all considerations.
And one point I'd like to make is that if the progression is oligo progression, then you may think about doing, say, radiation to a growing nodule or two, then continue the prior or the original ALK TKI. I think that's an approach that is reasonable.